Today I will be talking on the cultural and health disparities of individuals with eating disorders. A quick overview of eating disorders. There are three main eating disorders. There's anorexia, which is starvation, severely underweight for the most part. Bulimia nervosa is binging followed by compensatory behaviors. And there's binge eating disorder as well, where the individual binge eats but does not have any compensatory behaviors. 9% of the population of the U.S. will develop an eating disorder in their lifetime. People with eating disorders aged 15 to 24 are 10 times more likely to die than their same age peers, so it's a very intense mortality rate. 30% of individuals with an eating disorder have been sexually abused. Those with eating disorders have higher healthcare costs, lower employment rates, and lower annual income. There are many potential health complications from an eating disorder. A few are organ failure, low blood pressure, infertility, and heart damage. To get into the cultural environment, the media portrayal of eating disorders is largely thin white females in middle to upper class families. Eating disorders are also portrayed as simply an obsession with food, thinness, and body image. This portrayal is largely inaccurate because eating disorders do not discriminate against body size, gender, race, sexual orientation, or socioeconomic status. Eating disorders are also very complex and serious illnesses that can involve depression, substance abuse, anxiety, and low self-esteem. This inaccurate portrayal can be dangerous. It can lead to underdiagnosis of those who don't fit the thin white female stereotype, leading to poorer health outcomes. Family support in eating disorders can kind of go either way. So there is family-based treatment that has been used to treat anorexia and bulimia, and it has been proven to be very effective. So essentially, family-based treatment, there are three phases. Phase 1 is the parents are responsible for what their child eats, how much, when, they monitor their food intake, and they limit physical activity. This basically continues until weight gain happens and the eating disorder begins to recede. Phase 2 is gradually the patient is given back responsibility of their own food intake and physical activity. In Phase 3, a therapist basically just ensures that they all have gone back to normal and are healthy. Family-based treatment in bulimia has been used as well. The focus is less on the physical aspect and more on the comorbidities associated with the eating disorder and minimizing the secrecy and shame of eating. So it's more therapist focused. So effectiveness of family-based treatment when compared with individual therapy is family-based treatment has proven to be much more effective. Family-based treatment, 90% of the patients fell into good or intermediate outcome categories in like menstruation, body weight, and the eating disorder symptoms. This is compared with individual treatment with only 18% of the patients falling into these categories. However, as you see in this chart to your left, balanced families and families with eating disorders are kind of inversely related. So research has shown that the families of individuals with eating disorders can be more enmeshed and more rigid than balanced families. One of the most significant factors of the development of worsening of an eating disorder is troubled family and interpersonal relationships. Peers have a huge influence on those with eating disorders. In a study conducted in 2018, influence from peers was the most statistically significant predictor of disordered eating behaviors, followed by likability from peers. Eating disorders has been found to be very cyclical. Female family members of patients with anorexia nervosa are more than 11 times more likely to develop anorexia than those with no relatives with eating disorders. The legal and political system does not help those with eating disorders. Digitally altered advertisements are very common in the media that we consume, and there is a huge lack of policy to prevent these from getting out and from developing eating disorders. Unrealistic body ideals are seen in advertisements and can influence individuals' perceptions of their own body, potentially leading to eating disorders. Social media influencers also pose an issue when they sponsor laxative teas and other unhealthy methods for weight loss, and there is no regulation on these advertisements. The recommendation that Striped recommends is companies be held accountable for their digitally manipulated advertisements, or that incentives are offered by the government tax-wise to reduce digitally altered advertisements. Potential barriers in our culture for those with eating disorders is diet culture. Diet culture is rampant in the U.S. and perpetuates vulnerability of those with eating disorders. Diet culture can enable a new eating disorder to develop, make an existing disorder more serious, or force someone in recovery from an eating disorder to go back to their old ways. A few ways diet culture can do this is diet culture categorizes fat people as unhealthy and thin people as healthy, regardless of their eating or exercise habits. It's commonplace for doctors to recommend one-size-fits-all advice of lose weight for people who are fat and have a medical problem. There's no consideration for whether this person has a history of eating disorders, and this diagnosis could cause regression. Diet culture assigns morality to body size. Thin is good, fat is bad. This message causes individuals to chase thinness no matter the cost. Health disparities in those who have eating disorders in a low socioeconomic status is huge. Seeking treatment is essential to recovering from an eating disorder. Treatment for a serious eating disorder can involve extended inpatient care spanning weeks or even months. At minimum, treatment for an eating disorder would involve seeing a therapist and perhaps a nutritionist. Treatment involves taking time off work, paying a treatment facility or provider for care received, potentially finding childcare, transportation, and could require computer and internet for research. So, therefore, those with low socioeconomic status could find seeking treatment very difficult for these reasons and may experience a worsening of their eating disorder because they are not able to afford treatment because of lack of resources and money. Also, eating disorders are exacerbated by stress, and those with a low socioeconomic status are at risk to experience chronic stress and riskier health behaviors. Health disparities in race, ethnicity, and gender. As I've mentioned before, there's the stereotype that those with eating disorders are thin, white, and female. This can be obviously harmful for those who are not thin, white, and female with eating disorders. This can lead to underdiagnosis, causing seeking of treatment to be delayed or non-existent. In religion, many religions such as Islam, Judaism, and Christianity have fasting as a core principle and practice. Most religions don't require fasting from food if it can harm the individual if they have a medical condition. There have been a few studies conducted regarding fasting, religious fasting, and eating disorders. Religion has been found to be correlated with fewer disordered eating behaviors and lower body image distress, but has also been found to be highly correlated with more disordered eating behaviors and higher body image distress. With geographical location, depending on location, someone seeking treatment may not be close to an eating disorder treatment facility and may be required to travel. Those in rural areas may not have access to quality eating disorder treatment in their communities. Telehealth and telemedicine could really improve this issue. It could allow those in rural areas or those who are unable to travel to receive excellent eating disorder treatment, resulting in improved health outcomes. There are a lot of biases that those with eating disorders face. A few of these biases are listed here. So there's a bias that an eating disorder is the family's fault. Parents can be blamed by family, friends, and even medical professionals. In many cases, however, the family can be a huge support to a person undergoing recovery for an eating disorder, as in family-based treatment that I mentioned before. As far as weight gain goes, for those with anorexia, it is better to only gain some weight back through recovery. There's this weird number that being underweight is viewed as positive. However, it's essential that patients with eating disorders gain enough weight to avoid relapse and fully recover. Typically, those with eating disorders are viewed as those in their teenage years or young adult years. So, therefore, those in their 30s and 40s developing an eating disorder, they may go undiagnosed or missed, which can be dangerous. As I mentioned before, eating disorders have been classified as a female disease. So males or transgender individuals are more likely to go unnoticed if they have an eating disorder. Research has also shown that males are less likely to seek treatment. There is also a weight stigma associated with eating disorders. As I've mentioned, those with eating disorders, everyone thinks that they're thin, that they're starving. However, there is binge eating disorder and atypical anorexia in the DSM-5, which can both affect people of any size. Internationally, the issue of low socioeconomic status and the cost of eating disorder treatment could be resolved in countries with a socialist paradigm with universal health care. The health disparities associated with race, ethnicity, gender, bias, religion, and geographical location still exist internationally. And that is an overview of the cultural and health disparities of those with eating disorders. Thank you.